I call Dr. Prajakta DANDEKAR. She is going to present on retropupillary iris claw lens implantation in novice surgeon, a video-based retrospective analysis.
Hello. Good morning, everyone. I am Prajakta DANDEKAR from Shantilal Sanghvi Eye Institute. I am practicing cornea there. So my presentation is on retropupillary iris claw lens implantation amongst novice surgeons. So the background goes like because cataract surgery is the most common surgery in ophthalmology, but it has a learning curve, and to combat this learning curve, what we have done. So we have phaco development programs which were introduced by AIOS team. Then there are SICS training programs which various teaching institutes. Then there are IMAS training in which they have different models and even animal models in which you can study. And there is Help Me See in which there is simulation-based training for cataract, SICS as well as phaco. But what about the complications? Do we have any training for complications? No, we directly handle them on the table. So this study was to identify the difficulty which were faced by novice surgeons in retropupillary iris claw lens implantation and streamline the surgical steps by providing guidelines. So this was a retrospective study. We analyzed 17 videos which we operated in September 2023 to June 2024 by 4 novice surgeons. Novice surgeons were defined as surgeons who were efficient in doing cataract surgery. They have done more than 1,000 cataract surgeries, but they were not very trained in iris claw lens implantation. Less than 5 iris claw lens implantations have been done by them in early days. So the outcomes were measured as follows. These were the 14 parameters which were analyzed as primary outcome, and secondary outcome was considered as visual acuity, IOP and CME was documented. So the 14 parameters I'll explain one by one. So our results were the side port construction was our first parameter. So in iris claw lens implantation, we know that the side ports have to be at 180 degrees because the IOL haptics are at 180 degrees. So if when there are primary, when the surgery is done as a primary surgery, like the cataract surgery along with the iris claw lens implantation, generally the cataract side ports go at 10 and 2, and in iris claw you need at 180. So that was a difficult point, and if the additional side ports are not made, then the surgeons were struggling for this step. Then the second parameter was tunnel construction. So 100% tunnels were constructed in a 3-planar configuration. Then third parameter was triamcinolone acetonide, whether it was used. So 3 patients it was used, and all the 3 patients did not show any rise in IOP in the post-operative period. But one patient, the triamcinolone dye has gone behind the IOL, so there was difficulty in vision because of the dye. The second, the fourth point was whether PI was done. So 8 patients underwent peripheral iridectomy, and in 8 patients it was not done, and 1 patient had an iris defect. Then ACM was used mainly by the surgeon who was a posterior segment surgeon. So 7 cases were done using ACM, and 10 patients were, in 10 cases ACM was not used. And anterior segment surgeons, 10 cases were performed by anterior segment surgeons and 7 cases by posterior segment surgeons. So minimum time taken was 23 minutes, maximum was 100 minutes. 100 minutes because mostly combined cases were also included here, because the posterior segment surgeon in which he has done IOL, in which the late bag in subluxation was there in the posterior segment. The enclavation instrument, the most common enclavation instrument used was enclavation rod. The other instruments were 27 gauge cannula, iris repositor and Sinskey hook, and enclavation rod was found to be better because with other instruments there were cases of iris defects seen, and with multiple attempts were used instead because of the other instruments not able to enclave the haptic into the iris. And the other points were medial enclavation and circular pupil. So if you see this diagram on the right side, so this is a pictorial representation of the iris. So the sphincter pupillary muscle is at the pupillary margin, and dilator pupillary muscle is just behind it in the ciliary zone. So beyond the collaret, near the contraction furrows, if the enclavation was done, it was shown that the pupils were circular, and if there is medial enclavation, that is the enclavation was done medial to the collaret, then there was peaking of the pupil. So we found that the peak pupil was present in almost 9 cases, and in which medial enclavation was done. So haptic exposure was present in 3 cases, and IOL was subluxated intraoperatively in one of the cases, which was again reposited, and one case because of iris atrophy, it was subluxated. So this was secondary outcome. So 20/30 vision we got in 5 cases, and vision was 20/40 and 20/100 in 10 cases. Most common cause of decreased vision was glaucoma, corneal scar, diabetic macular edema, CME, post VR surgery for retinal detachment, full thickness macular hole, and epiretinal membrane. So these are the surgical steps which we streamlined. That we should mark the incisions, side port incisions at 180 degrees. They should be stab incisions with less intracorneal tunnel. And if TA is used, it should be used diluted so that it doesn't hamper the vision in the postoperative period. And PI should be mandatory. In our cases also, we got three patients who had raised IOP, in which one case was treated medically and 2 patients had to undergo PI by YAG laser. Removal of viscoelastic should be done behind the IOL, which could also be the reason of pupillary block. And hammer forceps should be pointing towards the haptic, which gives which helps in easy inclination. And inclination instrument should be as thin as possible to avoid iris trauma. So our conclusion was that iris claw lens implantation has a learning curve and requires analysis of surgical videos for optimal outcomes. So eyes undergoing repeat surgeries are prone to multiple complications affecting the final visual outcomes. Thank you.
Any comment?
Yeah, I think you are aware that it is a 4-minute presentation, is it not?
Yes.
If you too much overshoot, no, your marks will come down. Okay, so any presentation can be made according to the time. If you are given 8 minutes also, the same thing can be presented. 4 minutes also, same thing. So that is one thing you should be careful when you present the competitive sessions.
Yes.
And PA not done in 8 cases or something.
Yes,
PA
sir.
not done, how can it be a learning curve issue? Why have they not done a PA?
So because iris claw has 3 designs. So one is a biconvex design, one is a concavo-convex design, and one is a plano-convex design. So plano-convex design was a design which was used for anterior placement of the iris claw, and the other designs which were biconvex and concavo-convex, they were used for when the iris claw was used in the posterior segment, like when it
So
was.
this included both, huh? This included anterior
No,
and
this
posterior.
included the iris claw, which was posterior placement. So in posterior placement, sir, PI with many studies, sir, which we followed. So PI has not been mandatory for posterior placement of iris claw. It was mandatory for anterior placement, in which the plano-concave lenses were used.
Anyway, I don't use iris claw lenses, but I have heard people telling that the PA is a good thing to do.
Yes.
Otherwise, fine. This is an easy thing to do. This was all secondary, or there were primary cases also?
Primary also.
Primary also?
Yes.
Or primary only?
No, both were there.
All
So
are primary?
yes, both were there. Mixed. Sir. It's a posterior segment surgeon who got late in the back subluxation IOLs and all. So they are mostly secondary, and very few cases were primary. So 3 cases were primary out of 17. Mostly it were retina complications were there in most of the cases. So mostly all these cases have been operated by the posterior segment surgeons, or in combination with anterior and posterior segment.
Have these novice people tried this procedure in wet lab?
We haven't looked at that data.
I think we should teach them
Yes.
in wet lab 3 or 4 cases, so that
Yes.
they know exactly all these steps and then get the feel
Yes.
of how to enclave and all.
Yes,
It's easy to do in wet labs.
Yes.
Thank you.